My name is Gabriela Elcibar, and I'm going to talk about single-dose Oritavancin in the treatment of acute bacterial skin infection. Definition. This medication is an antibiotic used to treat serious bacterial infections of the skin. It works by stopping the growth of bacteria with a single intravenous dose, indicated for the treatment of acute bacterial skin and skin structure infections, ABSSSI, in adults.
Scientists often see opportunity where others do not. An example of this can be seen in the story behind Oritavancin, a drug that may not be on the market today if it wasn't for the science of PK/PD. Eli Lilly discovered Oritavancin a quarter-century ago, and like many long half-life drugs, they tried to develop it as a once-daily regimen. But for some reason, they couldn't get it through phase 3 trials. So in the early 2000s, Oritavancin development was taken over by Intermune, and they too tried to develop it as a once-daily regimen. Not seeing Orivancine's potential, they decided to refocus their company and sell it to Targanta. Targanta continued developing it as a once-daily regimen and invited us to work with them. However, after carefully evaluating the PK and PK/PD profiles of Oritavancin, our teams realized that the solution was not to administer it as a series of small daily doses, but rather as one big single dose. Targanta decided to shelve this idea now, but explore it later, after the once-a-day regimen got approved. So they submitted it to the FDA for approval, and after many months, the FDA came back with a rejection. Daily doses of Oritavancin weren't that effective. Seeing the potential in previous PK/PD data, Oritavancin was then acquired by the Medicines. With ICPD's support, they conducted further clinical studies to put this novel regimen to the test. With the data from these trials in hand, the medicines company submitted Oritavancin to the FDA as a single-dose regimen. And success. On August 19, 2014, the FDA approved Oritavancin as the first single-dose regimen antibiotic for complicated skin and skin structure infections. Reflect on that for a moment. The exact same drug was submitted twice to the FDA, yet it was the dosing regimen based on PK/PD science that made the difference between rejection and approval. This is what we mean when we say that PK/PD is essential to drug development. And in some cases, it is the difference that determines whether a valuable drug makes it to market and benefits patients. After all, isn't benefiting patients what drug development is all about?
Applications in medicine. Oritavancin injections comes as a powder to be mixed with liquid and given through a needle or catheter placed in your vein. It is actually injected slowly over 3 hours as a one-time dose by a doctor or nurse.
Our hospital has a number of different incentives to treat obviously skin and soft tissue infections and other protocolized infections. Obviously, first and foremost, and which is probably the biggest for us, is that we are just overwhelmed as far as census. So on any given day, our hospital is usually over 100% full. We have many patients waiting in the emergency department. PACU, we obviously have. It's not unusual for us to have elective surgeries that get delayed in order to wait for a bed that's available. So this is a big incentive for us to not admit patients, not only infectious diseases patients such as skin and soft tissue infections, but really any patient. So by protocolizing them and focusing on reducing admissions, maximizing outpatient therapy, even IV antibiotic therapy, and having early discharge is a big priority for us. So that's usually the big incentive for many of them. Now, with skin and soft tissue infections, the thing that's difficult is the patient population, at least here in California where I work, is a difficult patient population. They often live outdoors or homeless and don't have a home. They're often very mobile and not very stable. If you choose to do oral antibacterial therapy, compliance is a big issue. If you want to do outpatient IV therapy, Many of them don't have a home, so you can't send them home. And if you do have a home, we have a very high rate of methamphetamine and drug abuse. So sending them home with a indwelling venous catheter is almost impossible. So that subgroup of patients can be very difficult. We found from our own internal evaluations that these patients stay significantly longer than average in the literature, and that they certainly outstay what is called our DRG, or billing. So we know that for most of these patients, unfortunately, our hospital loses money. That's not why we do it, but obviously, when they sort of lose money and they stay much longer, and they certainly are much more difficult to manage. Anytime we can maximize that therapy as an outpatient and impact our census, it's important. We have sort of multiple protocols for skin infections in our hospital. The first is on the emergency department and outpatient side. So we look, for example, at patients, in defining diseases where oral therapy should be the standard of care. This, for example, is small things such as 1 to 2 centimeter abscesses, carbuncles, furuncles, cellulitis that's less than 75 centimeters squared. This would be classic outpatient oral therapy. That would be a guideline. If they obviously have larger disease, larger abscess, systemic signs of infection like a fever, tachycardia, service symptoms, some of those patients may get admitted. Some of them may be warranted for home therapy or outpatient therapy with maybe the long-acting type of glycopeptides like Dalbavancin or Oritavancin, where that provides us a single dose where we can send them home and have long outpatient therapy. We use Dalbavancin for that case, and on average, we probably capture about 20 to 25% of the patients that are candidates. We can certainly do better, but again, sometimes it's difficult to hit all of those. And lastly, when we do when they do get admitted, obviously, we like to maximize ways to get them home or out of the hospital. Examples of that would be if they can tolerate home IV therapy, we transition to that as quickly as possible. It might be some options for early oral therapy. We did, for example, in our hospital, provide free oral therapy for our patients. Patient hospital hospital pharmacy just filled, for example, doxycycline or trimethoprim sulfa. We carried it up to the patient, gave it to them for free to improve compliance. Or we may actually give them a dose of a long-acting glycopeptide like Dalbavancin, send them home a few days early, which allows us to free up a bed, optimizes therapy for the patient, and is able to transition therapy.
Pros and cons. Cons. The most common adverse events are nausea, headache, vomiting, lymph and subcutaneous abscesses, and diarrhea. Pros. Potential advantages include a convenient single-dose treatment that may shorten or eliminate hospital stays, no need for dosage adjustments in patients with mild to moderate hepatic or renal impairment, and no need for therapeutic drug monitoring.
ABSSI, or acute bacterial skin and skin structure infections, have a huge economic burden for our hospital, along with a huge clinical burden. Many times patients have to get admitted, and a lot of times they require IV therapy for a few days and then get discharged, and it requires the patient to take oral antibiotics. This requires the patient to actually take those antibiotics, and sometimes that doesn't always go as planned. The economic burden for these infections large in the sense that they get admitted and a lot of times readmitted for that same infection. Oritavancin and vancomycin, they're similar in what they cover. They both cover gram-positive organisms, including staph and streptococcus. In terms of administration, though, Oritavancin is a single dose, whereas vanco has to be given either once or multiple times a day, depending on the patient's renal function.
Issue applied in Ecuador. There's a lack of research and treatment with this drug in Ecuador. Bacterial infections are treated with drugs like penicillin, vancomycin, erythromycin, linezolid, and ciprofloxacin.
Yeah, I think ABSSI is something we're all dealing with, and the issues with patients and being hospitalized. So, we're seeing greater than 3 million emergency department visits on a given year. Many of these patients are being treated as outpatients, but more and more we're seeing linear growth in how many are being treated as inpatients. So what we see with ABSSI is mainly gram-positive in nature, streptococci, staphylococci, but I think the big worry for us is Staphylococcus aureus, specifically MRSA. It's becoming more and more difficult to treat. We're seeing issues with certain first-line antibiotics. So that's probably our biggest issue we currently deal with right now are the MRSA-specific patients. I think we're seeing an increase. We can look to our local antibiograms, and we're seeing more and more MRSA patients. And we're doing a better job at diagnosing them. I think that's part of it. And we're seeing a lot more recurrence as well. So as these become harder and harder to treat, it's a bigger burden on us and healthcare systems.
Conclusion. Distinguished by two mechanisms of action, inhibition of cell wall synthesis and disruption of the cell membrane, Oritavancin seems to be an effective one-dose treatment for acute bacterial skin infections and a promising antimicrobial alternative to vancomycin, and a more convenient way of administration.
I got it. So at our institution, we developed a protocol for appropriate use of Oritavancin, and one of those implications in that protocol is using Oritavancin to expedite patients who are admitted inpatient to expedite their discharge. So in this study, we looked at patients who received Oritavancin to expedite their discharge, and we looked at patients who received conventional treatment with vancomycin and oral antibiotics. In terms of cost avoidance, even though we spend a significant amount of money for the medication, which is about $2,700, we save money in the long run because we are reimbursed based on CRG or diagnosis-related group. And for us to receive that, it doesn't matter how many days the patient stays in our hospital, we get the same flat rate. When the cost of a hospital admission is $2,750 a day for a patient to walk through our door and sit in the hospital, not including any labs, tests, or drugs, or nursing time, and we only get reimbursed about $5,400 of that, we want to try to match that as close as we can. In terms of clinical implications, by using Oritavancin, our patients have less time in the hospital because we're using it to get them out. A lot of times we keep patients inpatient to just give them IV antibiotics because we maybe don't think that they'll take oral antibiotics, or they're have too severe of an infection to take oral antibiotics. So we keep patients in the hospital longer just to give IV antibiotics. But the Oritavancin completely eliminates the need for patient compliance. We give them the once infusion, and the patient receives antibiotic treatment for the whole course as they would staying in the hospital with IV. Additionally, patients have less recurrence of infection, as we saw in the study.
Thank you.